So welcome everyone, good morning. I'm Dániel Bednárik, and let me introduce to you my PhD topic, which is therapeutic strategies in Clostridium difficile infection. A few words about me. I'm a resident doctor in Heim Children's Hospital and a PhD student. My supervisors are Katalin Lenti and László Földvári Nagy. My SMS is on the trans and my statistician is Noemi Gede. We've got two projects, and let me introduce to you first project. This is comparing the effectiveness and safety of different therapies in C. diff infection in adults. A few words about the background. Why is it a hot topic? Why is it a really important topic nowadays? So this is the most common healthcare-associated diarrhea worldwide, from 20 to 27% caused by C. diff. Almost 500,000 cases were registered in the US in 2022 among adults and children. And in the last year, in 2023, around 30,000 deaths were registered in the US. And the incidence of relapses is around from 15 to 35%. Our aim is to find the best possible therapy against C. diff. Our clinical question: which is the best therapeutic option for C. diff infection? For this, we use the PICO framework, and our hypothesis was fecal microbiota transplant is the superior therapy for C. diff infection. We did our systematic search in the three main databases with this final search key, and at the end of the selection, we've got 111 eligible full text for the data extraction. Let me introduce to you our main endpoints. This is the cure rate, the recurrent rate, and the prevention. In this presentation today, I will show to you the cure rate globally, and as in subgroups, the recurrent and the non-recurrent cases separately too. We've done a network meta-analysis, so this is a network plot in the case of cure rate globally. There are knots and edges on it. Every knot represents here different kind of therapies against C. diff infection. The bigger knot represents that treatment was included in more articles like the others. So for example, here vancomycin was included in the most. Every edges show different comparisons among different kind of therapies against C. diff infection, and the number above it represents how many articles included these comparisons. For this analysis, we included 16 interventions from 28 studies, and a little bit less than 5,000 patients were included for it. Related to this network, we investigated here the cure rate of different kind of therapies against C. diff infection. As a clinician, it's a really important outcome how effective our therapy is. In this league table, the possible treatments are in the blue bars. They are arranged in descending orders according to p-score. In the area above the blue bars, there are the direct comparisons, while below it, the direct and the indirect ones, so the estimated ones, pulled together. Odds ratio is given in the cells. We compared one treatment from the left with one treatment from the right, and it indicates that how greater the chance of recovery. So for example, if we compare here FMT arm with fidaxomicin arm, we can say that in the FMT arm there is almost 6 times higher chance of recovery like in the fidaxomicin arm. The confidence interval is shown in brackets. If both elements are greater than 1, we can say the result is mathematically significant. So for example, in the previous example, the FMT fidaxomicin comparison, because both elements are greater than 1, we can say it's mathematically significant result. We marked all the mathematically significant results here with orange. This result, especially the fact FMT is mathematically significantly better compared with other treatment, and the fact FMT's p-score is also mathematically significantly larger like the other treatments one, we can say that in the case of cure rate globally, the best possible treatment is FMT. But let's see what's the situation in the subgroup. So let me introduce to you first the recurrent subgroup. For this analysis, we included only those studies which included patients who suffered from recurrent C. diff infection. For this analysis, we included 11 interventions from 10 studies, and more than 2,200 patients were included for it. This is our league table. FMT became the first here, and if we compare FMT with fidaxomicin, for example, we can say that in the FMT arm is almost 8 times higher chance of recovery, like in the fidaxomicin arm, and this is a mathematically significant result. Globally, we can say about this league table, FMT is mathematically significantly better compared with the other treatments, and according to the p-score, where the FMT's p-score is also significantly larger than the other treatments one, it suggests that in the case of recurrent C. diff infection, the best possible treatment is FMT. Now let me introduce to you our other subgroup, the non-recurrent subgroup. For this analysis, we included only those studies which included patients who suffered from non-recurrent C. diff infection. For this analysis, we included 12 interventions from 17 studies, and more than 2,400 patients were included. In this league table, fidaxomicin became the first in the row, and we can say about this league table, most of the antibiotics and FMT are mathematically significantly better compared with placebo, but among the antibiotics and FMT, there is no mathematically significant difference. However, according to this league table and according to our p-score, our analysis suggests that in the case of non-recurrent C. diff infection, antibiotic treatment should be the chosen one treatment. All analyses have strengths and limitations, of course. The main strengths, I think, we included only RCTs for our analysis, and the large number of included articles and the huge number of included patients, because we included more than 26,000 patients for our analysis, and we've got a lot of multiply endpoints. But of course, we've got limitations too, like the bit heterogeneity of the populations. In the studies, the therapeutic doses, the length of the treatments, and the follow-up times are not completely the same, unfortunately, and the presence of some risk of bias in some of the domains. We've got our main conclusion: FMT is statistically significantly better therapy in recurrent C. diff, and we've got implications for practice and research too. For practice, in recurrent cases, use FMT, and in non-recurrent cases, use antibiotics first. Or implications for the research: further examinations are needed in non-recurrent C. diff infection with the FMT treatment, because there are not enough examination yet. And the other thing, further RCTs are needed to find out which methods is better to use with FMT. We submitted our paper in the last week to the Lancet. Let me introduce to you a second project, which is comparing the effectiveness and safety of different therapies in C. diff infection in pediatric population. A few words about the background again. Why is it a hot topic? More or less it's the same like in the adult population, but let me highlight a few things. So in the last year, in 2023, according to the latest data, there were around 20,000 hospitalized children who had C. diff in the US, and the number of cases are growing and growing every year. So this is the fact why is it a hot topic nowadays. And the other thing which is really important, I think, this illness is really common for those children who spend a lot of time in hospital due to any other underlying diseases. So for them, it's a crucial thing to get the best possible treatment against C. diff too. So our clinical question, which is the best therapeutic option for C. diff infection, we use the PICO framework, and our hypothesis is FMT is superior therapy for C. diff infection in children too. We did our systematic search with this final search key in the 3 main databases, and we are after the duplicate removal. We've got almost 7,800 hits, and the title and abstract selection is ongoing now. So for summary, we published, or not published unfortunately, but submitted, and hope we will publish, we submitted our first paper in this June, and the second project we would like to finish in the end of this year. And the end, thank you so for your kindly attention.
Well, I can assure you that if your paper is accepted by Lancet, there will be a big feast at CTM. If I can have a very naive question, that is there any, I mean, does FMT has any potential risk or side effects?
Yeah, it's a really good question, and by the way, on the field, it's a hot topic, I can say that. So there is not enough information yet because it's more or less a new treatment. But till now, the literature thinks that it's rather safe than not, but further investigation are ongoing, so it's absolutely a hot topic on the field. Yeah.
Hi, thank you so much for your presentation. It was wonderful as always. I have two small questions. First of all, is FMT available here? And second, is it available for children in Hungary?
Thank you so much. Yes, so for adult population, it's a more common thing in Hungary. Rather, the clinics do it in Hungary, if I'm right. But in the pediatrician field, it's a really good question because, as I mentioned in my presentation, unfortunately, the number of cases are growing and growing in the pediatrician population too. And unfortunately, the more severe cases are growing and growing too. So this was the fact. In the Western countries tried first the FMT, and over there is more or less a common thing. And in Hungary, I can say that in the last summer, in our hospital, in the Heim Children's Hospital, the first FMT happened. And it was a really interesting case because it was an adolescent, by the way, who lived with IBD. And he has a lot of recurrent C. diff infections. So at the end, our gastroenterology team tried to help with FMT, and it was absolutely a success. So after it, thankfully, the recurrence stopped, and till now, he's absolutely okay with it. So yeah, we think that in the field of pediatric population, it will be a more common and important thing.
Congratulations on your great presentation. I just have one question. You presented that you have subgroups for the recurrent C. diff infection, and I was wondering what were the criteria used to define recurrency, like how many episodes were needed or something like this?
Thank you for the question. So according to the literature and according to the daily routine, we are talking about recurrence in the case of C. diff if after the initial, so the first infection, in the first 8 weeks, again a C. diff infection occurred. So this is the daily routine to use it. After 8 weeks, if during this 8 weeks period there was no C. diff infection, but for example in the 10th week, C. diff infection again occurred. In that case, we are talking about a new C. diff infection, so like a first initial one. Yeah, thank you for the question.
So, thank you for your presentation. Could you tell us something about prevention and how the current guidelines are decide what we should do?
Yeah, thank
Thanks.
you so much. I've got extra slides for it. Yeah, so this was our network, and which is interesting in this league table. So unfortunately, I haven't got enough time to present everything about it. But so it was really interesting. In this league table, the vaccination became the first in the row, and because the recurrency, as I mentioned, a really huge problem. This is the fact a lot of clinical trial is ongoing and were ongoing. And for example, this vaccination, it's by the way, as I show here, it's only one study. As you can see there, this C. diff toxoid vaccine, it was by the way a huge randomized controlled trial. But, and in our league table, it became the first in the row, but unfortunately, it's not unfortunately, but it was really effective compared with placebo, but this vaccine was not enough to do the phase 3 examination with that. So in the phase second, it was aborted. And which is really interesting, by the way, the current guidelines recommend only 2 things. One, if recurrency is a big problem, in that case, we can give antibiotic as a prophylaxis. By the way, this is vancomycin. And which is the other thing which is really interesting, I think, and the hot topic, that the probiotics are not effective against C. diff infection prevention. And by the way, for example, we checked probiotics too, and this is main findings of our study. We checked the mixed probiotics when they give more probiotics together, and the lactobacillus and the Saccharomyces, and neither the Saccharomyces nor the lactobacillus were effective, more effective like the placebo. But, and this is the last comment, I think, so you can see the oligofructose, that is the second in the row in our league table. This is a prebiotic, and if I know well the literature, more trials are ongoing with prebiotics, so maybe something will happen with prebiotics, but we will see it.
So currently, which I should give?
Only antibiotics can.
Okay,
so only vancomycin.
Nothing prevention.
But it's all nothing else. Yeah,
Okay.
yeah. Only and one last question, comment then. So you can see there this ACT and BEZ, actoxumab and bezlotuximab. This is monoclonal antibodies against C. diff infection, and this was another huge randomized control trials where tried to use this, and there were promising data, but it's only a really low evidence for it to help. So, but on this field, further RCTs are ongoing, if I'm right. So yeah, we will see. But currently, unfortunately, only the antibiotic treatment. Yeah.
Congratulations for your study and for the presentation. There are many different ways to do fecal microbiota transplantation. Are you aware of any studies where they compared which are the best ways to do this?
Yeah, thank you for the question. It's a really interesting question. And by the way, we've got plots about it too, but unfortunately, I haven't got here now. But it was a pairwise comparison, so unfortunately, we haven't got enough data for do a network meta-analysis in it. And I think it may be another topic and a new meta-analysis for it, but we checked the oral way or the colonoscopic way, and it was really interesting because the risk ratio difference was only 1%. So if I remember well, in the oral way, there was the cure rate 85%, and in the colonoscopic way, it was 84%. So it was not clinically and mathematically significantly relevant difference. But if I'm right, more RCTs are ongoing in this field too. So yeah, it's absolutely a hot topic to find out.
Thank you. One of your comparison was rectal bacteriotherapy.
Yeah.
Can you explain about this therapy? How was it done? What sort of bacteria were given?
So it's really similar to FMT, by the way, but not absolutely the same. And it's kind of bacteria which they gave for the patients with colonoscopic way to the colon transcendence, and they checked the effect of it. So this was the rectal bacteria.
Were they certain probiotics or which were applied?
Yeah, it was kind of that. Yeah, exactly.
Thank you very much. Congratulations on your results. So your second study, that will be also a network meta-analysis? Okay.
It's a really good question. We will see. So during the preliminary research, we found only 2 RCTs on the field. So we will see if we will find a third one or not. But if we found it maybe won't be enough for a network meta-analysis,
so
because...
Could you please shed light on what is the difference between the two and when one does need a network meta-analysis?
Yeah. So maybe there we can do only pairwise comparisons. We will see that. In this case, in the first project, the benefit of do a network meta-analysis is that in the pairwise comparisons, we can use only the direct data. But in the network meta-analysis, we can use the indirect, so the estimated ones too, and we can pool them for a network. So it's more information, and maybe the quality of evidence is higher with network meta-analysis. So this is the point, which is why it's better to use a network meta-analysis compared to pairwise comparisons. Yeah.
Great, thank you.
Congratulations, it was a very nice presentation. My question is whether you have a subgroup analysis on the first recurrence, second recurrence, and so on, because we know very well that the recurrence rate is increasing after the first recurrence. So this is one question. My second question is whether you had a change in the Clostridium difficile infection therapy in children as well, because our guideline changed since fidexomycin is available. And my third question is about your experience with FMT at Heim, whether the patient had UC or Crohn's disease, and whether the IBD changed or the activity of the IBD changed after the FMT, and who was the donor? That was the fourth one.
All of them really great questions. So the first one, I think, so the first one was the
FMT subgroup analysis on the first or a second recurrence.
Thank you so much. Thank you. Sorry. So in this case, according to the literature, we put in the recurrent subgroup only those patients who had the second or more than second recurrency, because according to the literature, the first recurrency, that's okay, that's not that bad, but after the second recurrency, we put them for the recurrency group, so this was the method for it. Yeah, but in the field of pediatrician population, it's really interesting, because in the IBD patients, it's a really big problem, and for this patient, for example, absolutely the activity of the inflammatory markers and his illness was absolutely down after the FMT. So it's not only cured the C. diff infection for him, but his IBD became better after the FMT.
Was he or she a Crohn's or UC patient?
CU.
UC.
UC, sorry, ulcerative colitis.
It's okay.
And for the donor, it's really interesting question, because for the current not guidelines yet, but in the Western countries there are a lot of strict regulation who can be a donor or not. And the literature recommend that the best donor should be a person from the neighborhood of the patient, the best from the household of the patient or any other relatives. This is the suggestion. And if I remember well, the fourth question, that was the antibiotics in the pediatric field. And it's absolutely a great question. Thankfully, in the field of antibiotics, not that bad the situation in the pediatric fields like in other treatments, in the case of other treatments. So the three most important, metronidazole, vancomycin, and fidexomycin, all of them are available for children too. And there was a huge multi-center international RCT about compared vancomycin and compared fidexomycin in 2021. And one of a Hungarian center was in it too. And this study, the result of this study, fidexomycin is absolutely safe for children, absolutely well tolerable, and the cure rate with it was higher, as in the case of in the adult population. But nowadays in Hungary, thankfully we didn't use now the metronidazole, so the national guideline rather recommend to use vancomycin for C. diff infection orally, and maybe later the fidaxomicin will the part of this guideline too. Yeah. So, but now only vancomycin we use the daily routine. So rather these pilot projects use the fidaxomicin yet.
What is the dose in children?
Dosage? It depends on, because the adolescents, because usually adolescents involved for this, they got dose like the adult population, so this 400 milligrams orally, not 200 milligram orally. And yeah, so this is the dose of it.
So, one very brief question. You mentioned that the failure rate of FMT was 15 to 16%. Did you find any information what actually predisposed these patients to have a failure for, or some predictive model or something like that? Thank you.
So, not at all, I can say that. So, yeah, this is the answer.
So congratulations, Dani, on your progress. I'm interested more in the risk factors for C. diff. So you know there are a lot of risk factors. Some of them are still controversial in the literature. Have you collected the different risk factors out of these 111 studies? And do you think different risk factors for those patients would benefit differently from different interventions? Thank you.
Yeah, it's unfortunately limitation of all, because the national guidelines, the national probabilities, that's not the same in every country. So unfortunately, it's a limitation of our study, because it's not, we haven't got the chance to do subgroups for it. So yeah, thank you for the question.
Thank you.